or good evening, depending on where you are in the world. This is a webinar brought to you by the Centre for Research in Health System Performance, which is a centre of research excellence, focusing on research dissemination and education to improve health system performance, particularly in supporting better value care, better population health. And I'm currently Director of Policy and a visiting professor there. Today's webinar is going to be focusing in on an increasingly important area for health systems, and that is how do we bring all of our collective assets together within local neighbourhoods to develop community-led initiatives that integrate care, focusing in around local populations, and in this case, older people. And we have 4 presentations coming up. We're going to take each of those presentations in turn, and if you have any questions or comments as we go through, please do add those into the Q&A box and we'll try to answer them live. If we're not able to answer them live, it's also our policy that we will keep those questions and then we'll work with the panelists to provide answers to you afterwards and make sure you get those. The presentations will be recorded and they'll be available on the CRiHSP website after the due course after the webinar concludes. And for those who have registered, slides will also be available for distribution. So I think with that, it's a great pleasure to welcome all of our speakers here today. And I'd like to begin by focusing in on Leon Stouthart, who's come from the Netherlands. It's 12:30 in the morning there, so yeah, I think she wins the late night award. Thank you for coming. We're going to have a focus on examples from around the world, focusing in on policies and then working through to the real granularity of what it feels and looks like to work with older people within local communities. So Leanne's going to talk to us about care close to home, neighbourhood-based integrated care for older people in the Netherlands, and how that is developing within the Dutch context. So Leanne, I'd like to pass over to you.
Yes, thank you very much, Nick. Let me just share my screen here. And as Nick said, it's very early in the morning or in the middle of the night, so please bear with me if I'm not really sharp or my English isn't perfect. Let's check. It should be in presentation mode. So, first of all, my name is Leon Stouthart. I work at Vilans, which is a Dutch Center for Expertise in Knowledge and Knowledge Development. And today I will talk a little bit to you about neighborhood-based care for older people, and mainly with a focus on how we are moving towards community-led care and support in the Netherlands. First, I will say a little bit more about my employer. Then I will give a short overview of the Dutch healthcare system. We'll explain a little bit on how our system is in transition. And furthermore, talk to you about how we organize or what we see in community-led focused care and support. So first, about Vilans. As I said, we are a knowledge organization in the Netherlands. We specialize in knowledge management for healthcare and support in the Netherlands. This means we do our research, we do our advisory trajectories, but we are not a public party and not really a commercial party. We're somewhere in between government and healthcare organizations. And our goal is really to make sure that everybody has the knowledge to deliver care for people who need it, to deliver care and support. So that's about Vilans. I am a senior researcher there with really a focus on integrated neighborhood-based care. And then a little bit about the Dutch healthcare system. So the Dutch healthcare system is based on several more or less universal principles and is governed by 4 basic healthcare related acts. So these universal principles in our healthcare system are access to care for all. Everybody has access to care, whether you can afford it or not, almost. If you cannot afford access to care, there are many government benefits that will help you pay your deductibles for the healthcare insurance, etc. We have a solidarity-based system through medical insurance. Medical insurance is compulsory for everybody and available for all. So again, if you cannot pay it, there are benefits, but you are obliged to have medical insurance in the Netherlands. And we really want to focus in the Netherlands on high-quality healthcare services. So the four major healthcare acts we have in the Netherlands are the Health Insurance Act, the Long-Term Care Act, Social Support Act, and Youth Act. And mainly the first three acts I'm going to talk about a little bit more. So the Long-Term Care Act is organized by central government. And this is care for people who need care in proximity for 24 hours a day, 7 days a week. So think about nursing home care, people with, for example, a further stage of dementia or with some somatic problems who really need care in proximity. This used to be care not really in proximity, but always available. But because of the staff shortages, a rising cost, which I will go in later, this changed into care in proximity. And in this Long-Term Care Act, once you move to the Long-Term Care Act, everything is paid from this Care Act. Before you go into the Long-Term Care Act, if you just don't need care in proximity for 24 hours a day, your care is mainly paid from the Health Insurance Act and the Social Support Act. Health Insurance Act is really focused on the medical care, for example, your GP care, district nursing, medication, up to 18 dental care is insured through the Health Insurance Act. And the Health Insurance Act is provided by the health insurance companies. We have 24 more or less public-private health insurance companies in the Netherlands who are in charge of the Health Insurance Act. And the government decides what is insured, what kind of healthcare is insured in the Netherlands. And the healthcare insurance companies, they have to make sure that care is organized through hospital care, through GP care, etc. And then we have the Social Support Act. And the Social Support Act is an act which is the municipalities are in charge for. So we have 380, I believe it's now 350 municipalities in the Netherlands. And these municipalities have the task to organize support for all their inhabitants. And they pay for the support. And they have to pay for it. So think about assistance, day activities, household support. So if you need help with cleaning your household, for example, volunteer, social support for homeless people. So this is not medical care, but this is more support and organized on the level of the municipality. And our healthcare system is like this since 2015. So 10 years ago, we had this major transition. And I believe right now, well, it's 10, 11 years ago, right now we really see the care shaping how it's supposed to be. I think if you have such a major transition in healthcare acts as we had in the Netherlands, it takes a really long time to really see the outcome of the transition. And I think we're there right now. We're getting there. So these are the three major acts. If somebody needs care, especially older people, who will pay for your care, who will organize your care. So indicators and access for these care acts. For the Social Support Act, what I said is every municipality has to organize care and support for their inhabitants, but every municipality is also free to organize the care and support in their own way. So what they could do is every municipality can have a different way of access to Social Support Act. It just really depends on where you live, how it's organized. The indications for the Social Support Act are through what we call kitchen table organizations. If you have a support question or support need for your municipality, you can call them. Sometimes you can just go to a visiting hour. It really depends on the municipality. Then there will be a conversation about your needs, really also focused on what you can do yourself, what your neighbors, what your family can do for you. And then look, what can municipality do for you? What kind of organized support do you need? And I believe in the Care Act, it's formulated that every municipality has the obligation to organize support in a good way. So they're really free to organize it any way they want to. Then we have the Health Insurance Act. As I said before, all citizens have the right to basic insured care in the Netherlands, which, for example, is district nursing, general practitioner, physiotherapy. Those are deductible free, the first three things. So the general practitioner, the district nursing, physiotherapy, you can just go to and you won't pay a deductible. If you need hospital care or medication, you'll pay a deductible from the Healthcare Insurance Act. And the general practitioner works as a gatekeeper in our system. So if you need, so we call the first three without deductible as first line care. If you need second line care, you can only get there through a referral of your general practitioner. And in second line care, you have a deductible. And then we have the Long-Term Care Act. As I said, it's for people who need care and support 24/7 in proximity. And if you need long-term care, you can apply at a care assessment agency for an indication. This is a neutral agency in the Netherlands. So your GP or your district nurse can say, well, maybe it's time to apply for the Long-Term Care Act. It's always for the citizen to decide if they want to. You're never obliged to apply for the Long-Term Care Act. And if you apply, it's going through a neutral agency who has a checklist to see if you really need care in proximity 24/7. And well, the referrals can go through district nurses, GP, social workers, but a citizen can also just apply themselves. So you don't need a referral, but the care assessment agency will make the decision whether you are eligible or not. So this is really like the basics of our system. And as I said, I will tell a little bit more about how our system is in transition. And I think this is a transition most major healthcare systems in the world go through, especially in Western Europe. What we see is we have an aging population. So the number of residents over 65 will increase from 3.8 million to 5 million in 2040. And will stay high until 2060. And it's good to know that there's 5 million in a population of 18 million people. So over a quarter of our population will be over 65 in 2040, and this percentage will stay high and stay around 25% until 2060. And at the same time, our government said a few years ago, we have to fix the number of beds in nursing homes around 130,000. So as you probably can tell, this aging population is also a population who needs more care. For example, in 2040, the number of people with dementia will double from now. And most of those people will have to stay living at home. So most people cannot go to a nursing home anymore. Nursing home beds are really reserved for people who cannot provide for care in their own home, really need those 24/7 care in proximity. But I will go a little bit more later on how we organize it for people, elderly people living at home. Furthermore, what we see major staff shortages. We have a housing crisis in the Netherlands where our housing market is completely kind of clogged up. So it's really hard to move from your family home to a home where you can easily live when you're elderly, example, with more accessible bathrooms, for example. At the same time, with the aging population, we see a decreasing number of informal carers. At the same time, these informal carers are more important because people are living at home and we have to do more with informal care because of the staff shortages. And we have, with the aging population, also rising costs. Again, I think these are not unique problems or unique challenges or pressures on the healthcare system, but it's good to go through them. So as a result, what we see is we have a growing focus on the community and care at home. We cannot care for our aging society with professionals alone. We simply do not have enough professionals and we simply do not have enough money to organize that. At the same time, we see withdrawing governments under neoliberalistic governments The government is saying more and more people also have to care for themselves, fend for themselves. And as a result, we see that more and more citizens organize their own care and support on a neighborhood level. At the same time, people need to live at home longer because we don't have enough nursing home beds anymore. But the people also want to live at home longer. People want to age in their own community, in their own neighborhood, with their own neighbors, in their own home. And as a result, we need another focus on togetherness in the civil society. So how can we organize, how can we answer this for these care needs in our neighborhoods instead of in our healthcare system? And maybe is community-led care the answer? We'll see. So how do we organize this aging society? How do we keep people living at home longer? So what I said before is all major care acts provide care in home, even the long-term care act. So people, it used to be the case that when you had an indication for the long-term care act, you moved to a nursing home. We don't have enough nursing home beds anymore. So people can also receive long-term care at home. And long-term care at home is really focused on well-being and support. So, for example, support with daily activities, support with grocery shopping, etc. But this also means that there's more pressure on the general practitioner, the community nurse, home care and social care. And we see a growing movement of caring communities in the Netherlands. And mainly for the caring communities, I want to go a little bit deeper in it because it's a subject that really goes close to my heart. But I also think it really is a way of caring for your aging society with not professionals alone. Let me see. What this means in practice is that somebody living at home from a social support act, you get provided with daytime activities, informal care and support, home adjustments and appliances is all paid through the Social Support Act. Health Insurance Act is general practitioner, district nursing, etc. But we also have these informal care and caring communities now who also provide for these people living at home. And if you are in a long-term care act, you have 24-hour access to care at home, daytime activities and treatment and transport organized through the long-term care act. So this kind of situation that can look like when you live at home. Let me see. So these caring communities, I'm looking at the time, I have to speed up a little bit. What are they and why are they so important? So these caring communities are community-led informal low-threshold activities. They can start from civilians want to organize care for their neighbors, but they can also start from a nursing home who says we want to do more in the neighborhood, we want to work more with informal care. And their main focus is really on connection, inclusion, and practical mutual help. So it's not care as a goal, and they cannot provide healthcare for their neighbors, but they often provide vital support. For example, more connection through activities, but also living a healthier lifestyle, have kind of sport or movement activities for elderly people. And they're really built on local motivation and not institutional mandate. So it's really kind of a grassroots initiative. And it all sounds really amazing and really great if we can organize it in the community in a way that people care for each other more. It's a really strong movement in the Netherlands right now. When I started my research in this field, I believe we had 1,500 caring communities in the Netherlands. And I believe in 5 years' time, we see a double of it. So you see in more and more neighborhoods, cities, villages, you see these caring communities popping up. But it's not all fun and games. There we see some we see some bottlenecks also because these caring communities are kind of organized outside of the system. So what we see, it's really hard to finance these caring communities. There's not in our healthcare acts, there's not a way to say, oh, we're going to shift a part of our budget towards a caring community. So as a result, we see that these caring communities, they need money. They need money, for example, for a neighborhood, for meeting points in the neighborhood, for example, or for just something as simple, just so they can buy coffee, to serve everybody coffee at a meeting hour. And as a result, because we do not have a way to pay them structurally, they really depend on yearly subsidies, which really makes it hard to develop and grow for a caring community, and really means that there's a lack of long-term stability. Then when we also see when there's not financing or no durable financing, it really prevents growth and planning for these caring communities. At the same time, they really run on volunteers. I believe all caring communities in the Netherlands, 98% is completely volunteer run. And as I said before, because of the aging population, we also see decreasing number of volunteers. I see a question in the chat. I will go into that later. What we see is that it's really hard to get commitment from younger generations, especially, for example, for board member functions. The question in the chat from Mohammed is, what are some of your current strategies to upskill volunteers to support your programs? And how do you sustain your pool of volunteers? What we see in volunteer training or upskilling volunteers, that really depends on the municipality. So as I said before, that's really the Social Support Act is one of the care acts who pays and organize also informal support. We see municipalities who really have like training programs for volunteers and really work with volunteers as side by side with professionals. I think that's a really great way to make sure your volunteers have the right skills, but also honor their position as a volunteer and not as a formal healthcare worker. Because for people who need care, it's sometimes easier to talk to a volunteer or easier to open up to a volunteer than to a formal healthcare worker. And it's really important that the volunteer and the formal healthcare worker are operating in kind of a tandem. And how do you sustain your pool of volunteers? Yeah, that's really hard. We have municipalities who have fixed amounts of who have money for volunteers, who can pay volunteers. But what we see is people are really busy in the Netherlands. As I said, we have a housing crisis. Houses are really, really expensive. Especially younger people, they just don't have the time to volunteer anymore. You both just need full-time jobs just to live in the big cities in the Netherlands. That's one of the big questions. How do we sustain our pool of volunteers? At the same time, we really see this community-driven approach to healthcare and to caring for each other. And I think if we can nurse that culture more, that it's normal to look after each other in a neighborhood, then we can sustain our pool of volunteers. But it's really a shift in culture we need. So another bottleneck we see is in collaboration with the system. So how can these caring communities can collaborate with the system without becoming the system? What we see is the system reflects is really much saying, oh, well, if you're going to provide care, you have to work the way we work. You have to provide care the way we provide care. And what I said before, the power of these informal networks is really that they aren't the system, that they are not a formal healthcare giver. This we really see different cultures. So much tension and colliding worlds. So I believe it's my last one. This is more a referral. We did some research in lessons for working with caring communities. So really, from a system perspective, how can you really help caring communities to develop? And we have 9 lessons. I believe the PowerPoint will be shared. There's an English article on our website which go really into these lessons of working with caring communities.
Thank you, Leanne.
So thank you very much. Yeah.
Yeah, no, thank you. And to the work that Freelance does as well. I think you answered the questions we went through. So, but I will ask you one thing. It's very interesting that other countries, for example, England, has some very purposeful ideas about developing neighbourhood-based models of care. That you talked about the Netherlands having a withdrawing government and the moving to caring communities is very much bottom up. Now, given the Netherlands historically has been one of those countries which has really advocated for integrated care, nurse-led primary care organizations, pooled budgets, new ways of thinking about how to do things, to what extent do you feel that it's odd that they're not deciding politically to start thinking about neighborhoods and leaving it up to, I mean, is this purposeful or is it literally withdrawing
I think
because it's
it's
not something that they want to really focus on? Because I found that fascinating
Mhm.
that there's not a purposeful policy.
Yeah, so I think these caring communities, it's really started bottom up as a grassroots organization because the government said we cannot care for everybody in the same way anymore as we did 20 years ago or 10 years ago. So people said we are going to care for our own neighbors. So we saw kind of parallel developments, and what we see now is how can we uh, really question from formal care and from our formal care organization, how can we integrate these grassroots communities in the way we always provided care.
Yeah,
So I think it was really much a parallel development, and now our system is reacting to the development
right,
they saw for the last 10, 15 years.
right. Well, that might be the way. Quite often, these
Mhm.
things, if it gets driven from the bottom up, then government might catch up. It doesn't always happen the other way around, does it?
Yeah.
Thank you so much, Leanne. We talked a lot in there about sustainability, so there are definitely pros and cons between the energy you get from a community grassroots movements versus the issues that are at stake to get sustainability. And I think we'll actually come onto that theme a little bit now as we move to our colleagues in Canada. So our next presentation will come from, we'll be talking about natural occurring retirement communities in Ontario, Canada. And we'll have Melissa Chang. She's the Senior Director of Integrated Care at the Nork Innovation Centre in Ontario, and Jen Recknagel, who's also the Director of Innovation Design at the same centre. We thank you both for coming to join us, and I pass over to you so we can hear a lot more about this initiative.
Thanks, Nick. I've shared my screen. I'm only seeing Jen and I, so just checking that everyone can see our slides.
We can.
You can.
Yeah.
Perfect. Thank you. And I will do a little shout out because I know we have some Canadian colleagues on the call and I know it's getting late. So thanks for joining and supporting us. I think just as way of introduction, my name is Melissa Chang. So I'm one of the directors at the Nork Innovation Centre in Toronto, Canada. I'm the director for operations and sustainability. And Jen, if you want to introduce yourself.
Yeah, I'm Jen Recknagel, and I'm the Director of Innovation and Design. Really, I don't know, those things are pretty fluid between the two of us, and we have a pretty big team behind us right now, some of whom are on the call. So.
Great. Thank you. I'm going to kick off and then Jen's going to go through the larger half of the presentation, but please keep the conversation going in the chat. We will find the appropriate time to answer the questions as they come through. And we may jump in as each other's speaking just to add some stories or insights as we go through. So just as context, I'll just share that we both sit at an organization called University Health Network, and it is the Canada's largest academic health research system. And so we are a specific team that is focused on new models of care, specifically around how do we involve community and look at social impact work and really bring the formal and informal parts of our systems together. So I won't spend too much time on our center because you can go to our website, but we have been around for about 4 years. Those of us like Jen have been at this in terms of investigating naturally occurring retirement communities for 10 plus years. Just as context, when we're sharing our information, we are currently active in about 30 buildings, and that represents about 4,500 older adults. We support some other community development work that allows us to reach another about 150 buildings. So when you just hear the model and the early results that we're starting to see, that's reflective of those numbers. So we're going to focus today on the model that we have. But of course, our team also, we are very fortunate in that this is I can't speak today. This is philanthropically funded, and we also have a multi-year research grant that is federally funded. And so we've been very fortunate to have some good support as we got set up and started. But just to be clear, there is no government funding for naturally occurring retirement communities right now. I'm going to go to our next slide. So just to set context around When we speak about naturally occurring retirement communities, we really started with looking at data, and how we are defining NORCs is it really is just a geographical designation. But in our case, we looked more specifically at NORC buildings. So they can be apartments where individuals are renting, could be condos where they're maybe owning the unit, or could be cooperatives. But it just so happens that organically, a higher number of older adults have lived there. So when we look at the data, we were really looking at buildings where it was at least 30% or more. In some cases, it's much higher than that, but at minimum, we were looking for that. Multi-generational buildings where they had at least 50 older adults, so that we could take advantage and look at the density and be able to offer services differently. In many cases, the trends we're seeing is that older adults are moving to urban environments and moving into low high-rise buildings. A lot of it is due to downsizing. I think we have about, 36% of those in our city. 36% of Toronto's older adults are now living in high-rise buildings in our city. So we're seeing that grow over time. And we will be releasing an update in terms of updating our data, but are seeing some growth even in the past 4 years that we've been active with the center. Just very quickly, so this would be a map of where we have the buildings. There's a number in the province that we reside in Ontario. You can see it's just over 2,200. That is more than there are long-term care homes and retirement homes combined. And so it's a very significant opportunity for us to take advantage of, take advantage of the density here and look at how we deliver supports in a very different way. And then I'm just going to go to this quickly. We said to Liang that we would look to build off. So there's a lot of similarities, I think, in the programs that you'll hear from today. And so we made a little agreement amongst ourselves that we would try not to duplicate where we could. So we'll highlight some things that are slightly different. But just to give context around Ontario's healthcare system, Ontario is publicly funded for all our core physicians and hospital care, and the province is largely responsible for organizing all care delivery. At a provincial level, there's a body called Ontario Health that coordinates all systems work provincially and regionally. And at the very local level, which you'll see in this third box here, is Ontario Health Teams. And so those are the groups that are largely responsible for the community local nuance. And then at the very bottom here, you have the frontline care delivery. And so just to situate us, our NORC model really, our community-enabled approach really sits between these two. So when Jen goes into the model, just to give you a sense of how we're situated. Jen, I will pass over to you and let me know when you'd like me to move on the slides.
Great. Thank you for that introduction. So I'm going to try to explain our model. As Melissa said, we've been up and running as a center for about 4.5 years. We were lucky to get some philanthropy based on some early work that we did working with community champions, and then had the opportunity to think through how could we connect that sort of informal network of residents and communities into the formal system. And so we've been able now to run this program in 30 sites in Toronto, but really with the intention of taking a research and innovation approach where we partner with communities. We purposefully went into a variety of communities so that we could understand how this type of aging in place program could work for different demographics. So for example, when you saw that map, we're in both the downtown core and the inner suburbs. We're in rental buildings, ownership buildings, social housing buildings, bigger buildings, smaller buildings, and of course, different socioeconomic sort of characteristics. And that was really so that we could sort of get a sense of what are the core elements of what makes this work, what can be adapted, and how do you build the pathways and processes around this type of approach so that we can share and learn with other colleagues and regions who are, really looking for solutions for, how do we help people age in place and age in community. So this is where we're at today, is what is what I'm saying, and I think there's been quite a lot of learning over the past several years, and so our model is a principles-based, values-based approach. First and foremost, it is community-led. We are rooted in the local strengths and the lived experience and shared leadership with people on the ground. Every community is different. Every building's different. We are very much highlighting, centering a relational care approach in all that we do. So that means it's really focused on trust building, and that trust and relationships being the center in what I like to say is really the grease of building integrated care. And that's both how we work on site directly with residents, with building partners, as well as with partnerships across the system, as well as within our own team, and how you sort of run a program that puts relational values up front, and to create that culture. Of course, designing for sustainability from the beginning means you have to create something that's adaptable, that can work in all these different kinds of contexts and can be responsive to local needs, and that it really is focused on how do we integrate with the system that is, while also driving change. So that's what you'll see on the outside is really our principles of implementation. Our core elements, there are three, the first being local leadership. And so we partner with local residents in the building, resident champions. We call them NORC ambassadors, and we actually do capacity building with these people. It's usually a group of 3 to 5, sometimes 7, depending on the building, of residents who volunteer. It's usually older adults. It's usually women. It's oftentimes it's younger people who have retired recently-ish, and are really saying, I don't want what happened to my parents to happen to me. I want to stay in this community as long as possible. So what can I do to help make this a really great place to live? And so we help bring those people in the building together who might be having those thoughts and talk with them about aging in place. How do you work with the system? How do you be a good community ambassador? And so we've developed a training program that runs in 6 months, 6-month cycles, and a bunch of workbooks and tools. Anyway, so there's the heart of it. Core element number 1 is local leadership. So you have those residents ambassadors, and they work with the on-site support, which is the next bucket. That's our community connector, who is a bit of a coordinator, a social convener, a health promotion type of background. Somebody who is on site. Currently, we have it set at 2 days a week. But again, that can shift and change depending on the capacity of the community leaders and how much they're able to self-organize versus how much support they may need. So the on-site connector is there to support the ambassador group, but also to connect with residents one-on-one in that relational way, so that there is a trusted third party in the building who they can go to for information, navigation. Who do I go to for what? How do I get this? Can you help me fill out a form? I'm worried about X. And so they really are doing that navigation support. As well as the third thing that they're doing is to work with residents to understand, to do a survey, to understand what the needs are, and to start bringing in group-based programming. And so this is usually in the health prevention, health promotion type of space, where we are seeking local partners, health and social care partners who are publicly funded, who are willing to come and do programming in the building. And so this could be foot care, it could be exercise, it could be support for loved ones caring for someone with dementia, could be a diabetes clinic, these kinds of things. It really does depend on what the residents want, and our team works to facilitate those connections with partners and to bring them into the building. And for those residents that, you know, most of the people who are living in North buildings are, for the most part, they're independent. It's more focused on, again, health promotion, health prevention, staying healthy and well, and getting access to the services and supports they need. But of course, there are folks who do have more complex or chronic issues that do need more support. And so for those people, they can go through our on-site support and get connected into our integrated health and social care team, which in our model currently is a virtual clinic that's a nurse practitioner run clinic. And so they're able to get rapid assessments. They're able to do early intervention. They're able to support people getting connected with primary care if they don't have it, or even act in that capacity in the short term if needed. And so that connectivity really goes from working in the community with connectors, building that sense of community belonging and support, through to group programming, through to connection into primary care and or specialists as needed. So that's the heart of our model. I think one thing just to say really quickly, and maybe I'm supposed to say this later down in the slides, but it's late at night, is that what we're really finding, these three models work in an interconnected fashion. And there is a tendency when we talk with people to say, oh, that's really great. Like, we can just take this piece over here and just do that and tell us where the building is. And the thing is, they really do work together. And so when you have local champions who are really part of the decision-making process, who are there making it their own, they really help to drive participation. Right? Like, you can have as much programming as you want. If no one comes, it's not going to do anything. And so when you have people in the building and they're doing the surveys, they're knocking on the doors, they're letting people know that there's a falls prevention clinic coming up, they're kind of getting the word out, they're holding coffee clubs. It really does start to create a culture in the building of, you know, of aging in place together, for lack of a better word. So we're finding that is why that element really matters. Another piece that we see a lot in the system is that folks say, oh, you have this building, that's great, they can just come over here to our service. It's so important in this and our theory of change that the services happen on site. And that's because it helps to build those trusted relationships. And of course, for older adults who are having a hard time with mobility, especially in the Canadian winters, having things right downstairs really improves their experience, but also their opportunities for access to care. I'm getting pushed along. So as I mentioned
moving us along.
It's okay, please do. As I mentioned previously, we did design this as this program as a research and an innovation initiative. And so we do have as Melissa mentioned, a large 6-year research project going on with a third-party evaluation partner from the Women's College Hospital in Toronto, and are working on a larger impact study using health system data to understand outcomes. But in the interim, we are doing our own program evaluation along these 4 categories of understanding how this program is affecting people in terms of building healthy communities, healthy connected social belonging, healthy people, healthy system, and healthy growth. And not to get into this too much, because we really are still in the early days. I think we have had baseline in year 1, in some buildings year 2 evidence. And of course, these things take a lot of time, a number of years to show results. But we are seeing that there is an increase in residents that feel they have a neighbor to call on for help, that residents feel a stronger sense of belonging. that we've had decreases in loneliness, as well as improvements in physical and mental health. We have seen the ability of the program to support attachment to primary care, in that having a trusted third party right in the building could sort of support people who might not necessarily be accessing primary care. And we are seeing a reduction in ED visits. The fourth category really is one focused on sustainability and how a program can continue in place over time. And some of the biggest metrics that we're seeing that we're super proud of is that the Ambassadors program actually started 3 years before the center got up and running. And so that's within 5 years, 94% of the groups are still self-sustaining. And I think that's a big question you get asked a lot when you're working with community is like, how reliable is it? Can they really go on? And so I think we're seeing that with the capacity building and support structures that we've built, that they're really able to keep going. Another one is that our system partners are really reporting that this is adding a lot of value. They're seeing higher turnout. They're having support in building programming that's more appropriate for local communities. Next slide.
I think we've got to wrap up, Jen, but so maybe we can I'll go to the next one here, and maybe we can also just share what we have in terms of content, and maybe we can take more questions at the end.
Sure.
Yeah.
Do you want to share this one, Melissa?
I'll just go quickly so we are now at the point really excited that we're actually able to expand the model. So instead of us launching from site to site, we're actually going from region to region. So from a system perspective, the model that you heard Jen describe, we are now expanding it in 6 other regions. And it's the first kind of inaugural cohort to expand it across the province. And then the other pathway for scale is much more at a community level. So there's so much need and desire for the work of older adults, and we know that's a precursor. So we're starting that at the same time. So you'll see kind of that grassroots support at the same time as regional pieces. We will send the slides out for sure, and maybe there will be time for some other follow-up, but we are sharing some lessons learned. Quite, excited about the insights we've been able to get because we've been able to go really deep into the programming. And so, the things that scale are not a fixed program. What really scales it is values-driven backbone support and really what enables the local leadership and trusted relationships. So we will leave it there. And Nick, I will turn it back to you. Thank you for the time.
Thank you, Melissa and Jen. That was really interesting and detailed and really getting into the heart of what these community-led models look like and the impressive progression that Norca's made and the challenges as well. I will take one question, but very quickly because we'll need to move on. Interesting question from Patricia, actually, Patricia Spindle, who talks about the condo property owners. Is aging in place hit against, the landlords and the people who might not necessarily want this, because she's talking about this maybe impacting on property values or the impression of a place. I think that's quite an interesting question. Did you come across that, or what is that something you did? Yeah. Can you say a little bit about that? Because I can imagine somewhere like, other countries might also come up against this.
Yeah, it's super interesting. It's definitely one that really smacks of ageism in terms of not wanting those older adults hanging about. I would say, we did, as I mentioned, go into a variety of types of settings, and it's mostly the condos, which is an ownership structure where people have more concern about this kind of thing. But I would say for the most part, a large majority of the condo properties we approached, that was not an issue. And it's mostly because the people who are managing these buildings, their staff are getting asked to do things all the time that are out of scope for their jobs, right? So a lot of pressure to, can you help me move this? Can you order a cab for that? Can you help me with this? Or they're just concerned about people who seem isolated. And so for the most part, it's not an issue. I think if it has had any, it can sometimes be one or two board members that can have the louder voice at the table. I
Right.
would say in most of our condo buildings, though, once the program gets started, it is open to everyone in the building. It centers the needs of older adults. They see what starts to happen in terms of the sense of liveliness, and most are converts. So it is
Okay.
a concern. I think
So
there
it's
is things that you can
so
discuss.
the concern is more perception than reality, and you have to get.
Yes.
Okay. So the other question, I will take it, and which is you mentioned that a lot of the volunteers. This comes from Mohammed Yusuf bin Osman. Mentioned that a lot of the volunteers are senior women, and you see it a lot in neighborhood community-based programs that the men are rather less engaged or more difficult to engage. Is that something you saw, or what's this? How do you get men involved, or how do you get men supported? Because often they're, the least likely to put their hands up to get support, and it's the women who have to drive
Mhm.
the show. Is that what you see, or is that a characteristic rather than a reality?
No, it's a reality. It's it is a lot of women, mostly women, but I will say that there's this wonderful group in Canada that started, I don't know if it started in the UK and spread to Canada, but they're called Men's Sheds. And it is an initiative that's specifically trying to get men to do types of programming and activities to reduce social isolation. And I bring it up because they said the best thing. They said women like to socialize face to face, and men like to socialize shoulder to shoulder. And so I think one of the things that we talk about in our ambassadors training is how do you engage people who have a different sense of what that looks like, right? And so it's part of that training to be able to put yourself into somebody else's shoes and to think about other needs. Like some people just want to be quiet in the corner, but want
Mm.
to be welcomed in. And some
Yeah.
people want lots of lively discussion. So it's part of that training and support to
Yeah.
help people think
So it's
in
not
more
just
inclusive ways.
not a gender thing. It's actually a very cultural thing. People engage. Thank you. Very interesting. We're going to have to move on, I'm afraid. And so we're now passing on to Australia. So which it's around 11:30 in the morning with myself and my colleague Fiona Morrison, who's online. This is a program that I was involved in from its inception called the All-Inclusive Care for Older People program. It's on the central coast of New South Wales, and you can see a lovely picture there of the central coast behind Fiona. That's actually a beach close to where we live, up to Boca Beach, and that's one of the communities. It's a more affluent community. I wouldn't say this is necessarily encapsulates the whole of the beaches on the central coast, but you get an idea that this is a beautiful part of the world. I'm currently Director of Policy at CRiHSP, as I mentioned at the beginning, and Fiona Morrison is the Community Engagement Officer for the ALICE program at Central Coast Local Health District. I'm now going to share my screen because I've got the slides here. Right, if that's okay, then we go forward. So I'm going to tell you a little bit about the concept first. I won't go into what the Australian healthcare system looks like, but the original idea came from an understanding from the local health district and its partners, building a primary health network that commissions services to support the integration of care between primary and community and hospital settings, to really focus in on how do we develop community-based approaches to support older people. And we came up with an idea encapsulated in the triangle on the left that somehow we needed to bring together an understanding of how do we integrate care and services more appropriately around older people's needs, but also in the way that we've been talking about how do we connect communities more together by drawing on all of our community assets in that neighbourhood to support older people within those communities, and also address healthy placemaking. How do we change the environment around which older peoples live that can impact positively on their social determinants of health? And it really focused around two key concepts. One was the idea of an Alice Health kiosk, now called, I think it's called a community connections kiosk or connections kiosk, connections centre, which uses community engagement officers like Fiona, who support older people in identifying their needs and interests, understanding what they might like to do socially, forging community partnerships for them, and engaging, making sense of the world that they're living in to give them information and advice, but also through that to get support from link workers in the way that social prescribing might move towards link work is a very similar idea, that might support older people with specific needs and to get coordinated support. And here's a schematic of what that support might look like. So link workers might support needs assessment and collaborative care planning, identify services, have the skills to support people to self-care, to health coach, provide relational continuity and facilitate ongoing relationships. And all of that is because we have a delivery landscape that's very complex and fragmented. We have the same sorts of progression in terms of older age needs that Leanne talked about at the beginning. And lying behind what we did, the first thing was, what's the case for change? So the need for something like this neighbourhood-based initiative was a response to the increasing demand. So this is not only the numbers of older people who are turning up into hospital that don't need to be there, but a recognition, certainly on the Central Coast, that by 2036, we're going to see a 40% increase from today in the number of people aged over 70. And that's going to almost get to nearly a quarter of the population. So very similar to what Leanne's talking about in the Dutch context, we're saying the same thing in the regions of Australia as well. But demand is also set to outstrip supply. So the diagram on the right is really about the numbers of older people who are looking for home care packages. And home care packages are the sorts of things that older people can be eligible for. If they have social needs that they need to be looked after with. So usually these are frail older people who require support around the home. And there are a number of different types of intensity of packages that they might be able to be provided with according to those needs. So the diagram is describing that growth up until 2022. But what we were able to articulate was that level of demand was going to triple from around 4,000 older people on the coast to 12,000 within around 6 years. And at the same time as that demand is tripling, the ability of people to access nursing home support, which people were going into, was flatlining. So we got all of this sudden increase in year-on-year needs, but having to soak that up through forms of home care support. Now we're going to be able to cope with this rising level of demand. So when you look at that in terms of the social care side and you look at what's happening on the healthcare side, you've got a perfect storm of demand outstripping supply. What is it that we're going to do? We also undertook a joint strategic needs assessment between the health authority and the primary healthcare network, which really focused in on population and social characteristics such as age and building type and livability, also looking at health conditions and risk factors. To come up with the map on the right, which you see as a kind of a heat map of different neighbourhoods across the Central Coast where older people will be most in need of care and support. And you can see that it begins to filter into that area, into the top northeast area, where you have a lot of older people living in social isolation with difficult access, not only to healthcare facilities, but also to things that they need to keep them healthy and well as they progress. So I suppose politically, this is what we're trying to do. This is the sort of slide you would give to the people we were seeking to fund the project from central government, both New South Wales Health and the Commonwealth, which looks after the whole of Australia for social care and aged care needs. That simultaneously we're seeking to enhance patient management in the community through addressing socialisation, mobilising community supports, supporting people directly with their complex needs through assessment and planning and relational continuity and care navigation to the services that they need, supporting care in the home environment through health coaching or rapid access to care, ongoing patient support, and then as a result of that, maybe being able to have greater capacity to respond into the community to older people's needs, and therefore potentially seeing this reduce in the need for institutional care. This is the logic, I suppose, behind what we were trying to do politically. But more importantly, we went into the community consultations with older people living on the Central Coast. The first two things that they said in the first consultation, literally the first thing that they said is people in our area, in this case this was Long Jetty sort of area on the coast, and if you're British here, it'd be like an old-fashioned seaside town, increasing numbers of older people. But they would say we're screamingly lonely. We've got nowhere to turn for information and advice. We're feeling increasingly insecure in how we're going to access services. And the walls of our life are coming around us as we grow older with nowhere to turn to in order to be able to support ourselves. And what we see also, they were saying there are a few services that help us address this. There's no connection to community. We're relying heavily on GP services in the hospital system in a curative model of care, and everything's complex and fragmented. It's all online. We don't understand what we need, and we don't know who to turn to. It's a very crowded landscape for everything that we need, hundreds of different providers that we need to turn to. So it's become a very fragmented and isolating experience of which we need to make sense. And the other thing that we did over a year, actually, with Hunter Medical Research Institute, got a health economics unit, is turn this into money. So we're able to look at the evidence base and look at the data we had in our health and primary healthcare systems to try to come up with a costed business plan for what the estimates for ALICE would look like if we're able to do this maturely over a number of years, and breaking it down by neighborhood. And what we're able to see is very similar, actually, to kind of case management programs where you get specialists working more directly in primary healthcare for chronic diseases. We are also able to demonstrate a client benefit of around 5,000 Australian dollars per older person per year. So in the ballpark of other programs internationally, we've been able to demonstrate this with the additional quantifiable benefits of the societal benefits that the health kiosk and the healthy placemaking would come to. So we spend a lot of time trying to underpin the ALICE model through this kind of evidence, and importantly, also curated a governance system whereby you had health and the local council looking after social care needs, and the primary healthcare network looking after primary care needs, and others coming into an alliance to oversee what we were trying to do. And as a result of that, whilst we didn't get the big money from government to really do it at scale, we did get money to develop a minimum viable model. So during the financial year 24-25, we did a pilot implementation at the entrance on Long Jetty, which represented this. And this was to offer enough features of this original concept to attract residents to participate, to support ongoing co-design of what this concept might look like for them, so that we're able to tailor it according to their needs and wishes in their local context. And as a result, we came up with this twice monthly number of sessions with older people at a local over 50s club, a local health centre, which included health promotional activations, networking, co-design sessions, and increasingly access to information about what be available locally to them. We established a local residents committee and started to move forward in the development of these neighbourhood health approaches. And here are some examples on the left of what we're doing. Got some co-design activities at the bottom. We've got some particular activities at the top. On the left-hand side, from how do we get access to carers? How do we navigate my aged care, which is an issue to get all the care and support you might need at home, plus sessions that were health promotional in terms of the equipment that you might need to make your life easier at home, falls prevention, and so on. And our evaluation with a number of residents, very similar to what you're hearing from Canada, is that people really appreciated this. The quality of sessions were good. People were reporting new knowledge and the ability to apply it. And as we developed the idea of the health kiosk and the health centre, the vast majority of people were in favour of something like that. And we also had some narrative feedback. The narrative feedback was a bit more challenging because participants valued their voices being heard. But even here, they felt they wanted more time to collaborate and understand what was going on. So in a sense, whilst we felt we were doing co-design quite well, I think residents felt it was more of a consultation. So this has been at the forefront of our minds of how do we really get community leadership in what we're doing. And following what we've been doing that, we've actually managed to roll this out into 2 neighbouring communities and changing the nature of the model as well. So to tell us a little bit more about that, particularly in these 2 new communities, I'm going to pass over to Fiona, who's been leading these projects over the last year and a bit. Fiona.
So yes, I'll just give you a top level view of this and a bit of quick context for these 2 other neighbourhoods. So these were nominated as a matter of, as Nick said, were a priority of need and advocacy from our co-design team, from the community. So Tukulunora Head is probably only 10 kilometres from Long Jetty, the entrance. So similar in locality, demographics and geography, near the coast, high density of people over 70, 21% of the population there, spread over only 10 square kilometres. So similar to Long Jetty, our host organisation was the local 50+ centre, the seniors centre, and we established through a community engagement strategy with the members of the the 50+ centre and other local residents, how we would deliver the Health Connections kiosk there at their centre. So as part of that, we've been doing that twice a month and meeting people one-to-one who are members of the centre, but also local residents who hear about the programme. I've also been undertaking a community asset map of all the different services, both for-profit, government health services and local not-for-profits, as well as individuals who are there to support our aim of keeping people happy and well at home. So there's also the healthy placemaking activity that is coming up. We've run it in other areas, which is called Age Well, Live Well Forum. So that's a cluster of health promotion presentations, as well as some information stalls and an opportunity to connect with service providers and find out more about what's available locally in your neighbourhood. So very place-based approach for that. So similar to the Longjetti one, so it's more of an extension in some ways, but obviously it's its own neighbourhood, it's its own place, and we've gone through a co-creation process there with the local residents advisory group to actually implement it. So Nick, if maybe you want to move on to Mangrove Mountain, which is quite a distinct area. You can see the map at the top there. It's everything on the west-hand side of the freeway, the red line there. So yeah, very rural area. 100 times bigger. It's 1,080 square kilometres, with about 12% of that population being over 70. And I think that reflects the fact that it's harder to live in a rural area. There's only one person per square kilometre, whereas in Toukley there's 203 people per square kilometre. So you get a sense of the fact that people are living often on their own, on rural properties, and it's quite difficult for them to get the support that they need. So in terms of implementing the project up there, we sort of went back to basics. So used the place-based principles. So we were looking at understanding the place, partnering with the community, getting government working together, empowering people on the ground, and making the change stick, which is the last part I'm doing at the moment. So we had several public meetings, and that was in part organised by some of the co-design people from Longjetti who also live in that area. So they were very motivated to get this happening in their local area. We identified the local issues for the target cohort, the over 70s there. And we developed an Alice minimum viable model co-creation representatives group specifically for this area to get the process up and running there. Through this process as well, we populated the community asset map, the framework tool, so to look at what physical infrastructure, social infrastructure, the different services that are available up there. One of which was the local health district that I work for, have a community health centre up there. It's not permanently manned, but it is a physical infrastructure asset that I made good use of and have located the Health Connections kiosk there. That's there twice a month. So we determined the local priorities and we created a multi-action plan to address these. One of those, as I say, was the implementation of the Health Connections kiosk up there to be a permanent access point for these activities there twice a month. Maybe, Nick, if we can go on to the next slide and we can look at what we've implemented up there since July last year. Nick, can we move on to the next slide?
Yeah, you should have that.
Yes, do now, thank you. So there's three main areas, and this relates to that triangle for the Alice Health Connections, for the health implementation activities. So integrated care provision. So the kiosk there, local, as I said, located at the community health centre, has enabled a collaboration between the local health services that do run from there for older people, including community health nurses and the palliative care nurses that support the local community, both in their homes, but also those people can access the health centre. And some of that has actually been me supporting the carers of their patients and helping those carers get access to the support they need in order to continue caring for the older people in place. We've also connected a virtual care program initiative for those individual patients and their general service provision. So, for example, to be able to access telehealth from the community health centre with the support of the community nurse. And that's something that the local health district is trialling at the moment. We also have caring communities there. So we facilitated the localisation of workforce to deliver aged care services to Mangrove Mountain residents. And that was a key issue for those who services who were unwilling to be able to deliver services in such a sparsely populated area. They were finding a lot of their allocation for hours being taken up in terms of driving there. So we also had local people wanting to deliver aged care services to their communities there. We also had a local aged care services expo, so bringing the services to the community. And there's some pictures there at the bottom of that. And we have another one planned for July this year. The last part there was healthy placemaking, and that's something that where we've been able to behave as a catalyst to create a pilot project by the local not-for-profit provider of community transport to address their access issues there. There's also been a community-initiated not-for-profit group to establish a regular social connections event, because social isolation was a big issue there too.
Thank you. I know we're running against time, but you can see how this is very different to Canada. I can imagine 1 person per square kilometre is somewhat dizzying to people in Singapore, given I don't know what the actual number is for Singapore. But there's some really interesting things here. So I just wanted to ask, maybe Fiona, if you could say, from the learning and from experience to help neighbourhood-based projects operate, what would be the 3 key things that you would think of, and how do you engage people, older people in particular, to help these kind of programs operate? Are we just on mute, Fiona?
We started broadly, and that was promoting what we're doing at community-based events, local markets, that kind of thing. So I think it's really important to have a good representation of older people there. There's often some natural advocates and people, as we saw from some of the other presentations, maybe the older women in the community, but we wanted to ensure that we had a very broad range of people involved. We're lucky enough to have a local community newspaper there. Many of our local papers have disappeared over the last 10, 15 years, but there's an independent newspaper there, and they were very supportive of our initiatives. So we had people who were coming along to those public meetings, finding out a little bit more about what was going on, letting us know what the issues were, and then self-nominating to become part of the advisory group for the co-creation. They had a range of different skills, a lot of lived experience, but also they had skills themselves that they wanted to come along and bring to participate. I think a lot of the engagement stuff, as Nick would probably agree with the co-design from Longevity, is about managing people's expectations as well as personalities, and facilitating and making sure that everyone has a voice in that process, and also understands what they're involved in, what some of the barriers, participation in terms of engaging services, that kind of thing is as well. So, and I see quite a lot of resonance in what I do, and also those site-specific roles in the NORCs as well. So that's good to hear.
Thank you, Fiona. We need to move on, but I think you get a sense of feeling from the last 2 presentations just how much these neighbourhood-based projects are not necessarily system-led. They seem to be very much community-driven, community-led. And part of the question there is, what do health systems do to support that to happen? Given that a lot of this seems to be around building capacity for the communities to be able to self-organize themselves to some extent. I'm getting that feeling. Anyway, we can debate that. Look, we've got 15 minutes left of the presentation. I want to make sure that Dominic gets a really good opportunity to speak. And thank you very much for joining us from the Agency for Integrated Care. I think Singapore's on a really interesting journey towards supporting its seniors through Age Well Singapore and Healthier Singapore. Thank you for being with us, and I'm going to pass the floor to you.
Hi, very good morning to everyone, at least from Singapore. Very good morning. Thank you very much. I'm Dominic from the Agency for Integrated Care in Singapore. The Agency for Integrated Care, or AIC, coordinates the various elder care services in Singapore in the hope of helping seniors in Singapore to age better. So perhaps to begin with a quick background on Singapore's demographics. Our population is aging very rapidly, with a 55% increase in seniors that we expect. Seniors are also living longer. At the same time, our seniors are also becoming frailer on an age standardized basis, and they are also becoming more socially isolated. In addition, we do see that our seniors also have a earlier onset of chronic illnesses, and some of this does contribute as well to their frailty conditions. At the same time, in Singapore, we do have a falling birth rate. So we do have the seniors also then have fewer dependents going forward. Whereas in the past, when the birth rate was higher, as individuals aged, they could look to their siblings for some support. They also had more children for support, but with a declining birth rate, the ability for informal support to be provided has also decreased. In this regard, there's then a need for us to come together, whether it's government, as the community, as well as various social service agencies and care providers, to better support seniors to age in the community. So our goal is to help seniors to stay healthy in the community for longer. We see aging as a journey of at least 30 years. From the time that seniors turn 60, based on our internal statistics, seniors generally have an onset of frailty sometime around the age of 75. That's the inflection point. And from that point onwards, the proportion of seniors who become frail grows quite exponentially. And so for seniors who are well, our goal is to increase their years of good health. And as seniors become more frail, as we all surely will at some point in time, is to try to reduce that number of years of frailty. And with that in mind, for the well seniors, in practice, what we do is we try to work as a community of partners to help well seniors to stay healthy and active for as long as possible, and also to keep seniors engaged. A key focus that we have is targeting frailty, because as seniors become more frail, they may go out less, and that also contributes to social isolation as well as mental health issues. In the area of frailty, an area that we're actively exploring in recent times is looking at not just delaying the frailty, but looking at how to reverse frailty as well. And in order to do that, we try to identify and intervene earlier in needs and help seniors to be supported and cared for longer in the community. Our long-term goal is for seniors to be healthier for longer, and also to moderate the growth of the healthcare cost in Singapore, which is becoming quite unsustainable. So a lot of the efforts that we take focus on addressing the specific needs and concerns of seniors at that particular stage that they are at. So for seniors who are frail, a key concern is that of awareness of whether services are only for the frail and the vulnerable. And I think this ties to what Nick mentioned earlier about helping seniors to become aware of services earlier, and also trying to bring them to the awareness of the support ecosystem early. As seniors become frailer, it's about supporting them with care navigation and also simplifying that process for them. And as they become very frail, it's about trying to wrap care around them rather than requiring them to try to go to different places to access services. So upstream for the well seniors, since 2020, Singapore has increased the number of community nodes for active aging, or what we call active aging centers. Whereas in the past, a lot of these services of supporting seniors to age well was targeted at those who were of the lower socioeconomic status, staying in rental flats, for instance. We have now adopted a population-based approach to doing this. It is critical for us, and hence, over the past 3 years, we have increased the number of such centers in Singapore by 60% to about 231 today. And 4 in 5 seniors have an active aging center that's closer to their home. We have also expanded the range of programs to try to help seniors to stay well, whereas in the past, the programs primarily targeted the uh, social aspects, helping them to build social connections, expand their social networks. We've expanded the range of programs to include physical health, cognitive volunteerism, and learning, in the hope that this would be able to attract more seniors and help them to age well in a manner that's more holistic. In this regard, over time, we've also tried to support centers to be able to enhance their environment. So in the middle photo, for instance, we've seen centers set up e-gaming active aging programs for seniors to game. And I'm told that when pitted against their younger counterparts, some of them can actually do quite decently in some of these gaming activities. And some centers do also organize competitions because it gives seniors a shared goal to work towards. And in order to engender providers' ownership of seniors, in Singapore, we've recently introduced place-based care and tried to organize care services into what we call sub-regions. In some of the earlier presentations, I believe my fellow panelists referred to this as communities. I think for us, we refer to them as sub-regions. They are essentially the basic unit of how we organize care services, and we do so into 85 sub-regions. Our intent of doing so is so that providers which are familiar with delivering the services will over time begin to own the health outcomes of seniors within that particular sub-region. And this is quite different from the earlier state or the current state to some extent, where it is largely a transactional type of a service delivery model, and the senior then has to navigate different parties. So we're trying to engender some degree of ownership among a community of providers. And to do that, one of the things that we try to do is we try to provide our partners with a common view of how seniors in their sub-region or their community are doing, so that in addition to implementing services and bringing care, wrapping care around the senior, they can also use the data to start thinking about what are some of the priorities or concerns of seniors in that particular area. And it also helps them to be able to develop more preventive type of services. And so the way we are working towards organizing, and we are currently in the process of doing this, is that for every sub-region, there will be an integrated community care provider that will journey with seniors. And for any given senior, that provider or consortium of providers will plan for and coordinate services to meet the needs of seniors. And these providers deliver services across the aging spectrum, as I shared earlier, whether it's active aging centers for well seniors, or as seniors age, some degree of rehab services, and subsequently home personal care services when they become homebound, as well as home therapy services. And the idea is that regardless of which of the providers or services a senior has to interact with, because these various parties involved in delivering the services work together as a consortium of partners, the senior will have a common experience. There will be shared care planning so that the senior doesn't have to talk to different parties and get supported with different interventions or views of how interventions should be developed, and for then care to be delivered in a more seamless way. To this end, we've tried to introduce InterRI as a standardized assessment tool. Part of the challenge that we faced in the past is different care providers each used their own tool. And in the absence of a communimetric tool where everybody spoke the same language, it became very difficult to plan for and to coordinate care. And so we're shifting towards having a standardized tool. And the most recent initiative is that in towns where there's a higher density of seniors in Singapore, we are trialing this notion of what's known as age-well neighborhoods, where we will try to bring active aging services even closer to where seniors live, whether it's community touchpoints or common spaces. We're also trying to expand the role of the neighborhood nodes of active aging centers to be able to work with some of our health systems to have community health posts to help them with chronic illness management, for instance, as well as some of the very basic healthcare services. And I think similar to what Lian mentioned earlier in the Netherlands, currently for our home-based care services, they operate largely on a 12-hour model from 8 in the morning to 8 in the evening. And so what we are trialing in the coming years is also a 24/7 type of support to deliver after hours and ad hoc support closer to seniors' homes. And we are also looking then at beyond the software of the various services, how to improve the hardware in terms of senior-friendly infrastructure. And our goal is that through all of this, we hope that compared to the current state that you see on the left, where the senior has to talk to different providers or could not access active aging programs because it was not a population-based approach, or have to keep changing service providers every time their needs change with no one party to be able to plan for and coordinate their care, there will now be this one party that the senior will be able to go to, whether it's to access active aging programs or to access or to journey with them over that 30-year aging journey. And I think, as was mentioned earlier by Fiona, I think something we're trying to do actively is also to bring local communities into this picture. What I've just described is a sea change. We face similar manpower constraints, and we're actively thinking about how, for instance, we can introduce or more actively push micro jobs, for instance, so that seniors can better care for other seniors staying in their vicinity. I think when we do all of this, we bring the hardware and the software together, we build communities of care, and this become neighborhoods that we hope seniors will find are great for them to age in. So thank you very much for listening.
Thank you so much, Dominic. That's really interesting to see all of the strategy that lies behind what you're doing. The ICCPs, are they contracted providers? Are they government providers? Are they alliances? I know they're emerging, but are they different types? Because that's really just a very essential role, isn't it?
Yes. So currently they are contracted with government to deliver the various types of services. In terms of coming together, I would characterize them more as partnerships at the moment. And government has not came in to enforce that they must be legally binding consortiums, because we recognize that relationships and trust take time to build. And indeed, we are trying to move away from a transactional model alone to one that engenders ownership.
Okay. So it's a fluid kind of development of it. I had another question in the chat around the numbers of seniors that actually attend the AACs, the level of engagement that you see, and how maybe say something about that and potentially how you're seeking to increase it.
Yeah, so on average, every active aging center is assigned a population of about 2,500 seniors on average to take care of. And of this, about 500 of the 2,500 seniors, about 20%, are more regularly engaged by the AACs. And we're okay with that because we recognize that seniors may have their own informal sources of engagement, and seniors have agency and choice to tap on other support services as well. So the intent was never for the active aging center to be the sole party actively engaging all 2,500.
Yeah, thank you. So the other thing that occurs to me, and I see it also in the chat, is one of the things you hear very strongly is the role of seniors in Canada as ambassadors to the system and drawing other seniors into it. So using those social networks to also gain a movement to, again, grow the sort of community leadership behind things. See a little bit about that in Australia. Is that something that you're also seeking to do, is to grow that kind of, not only the participation, but the community leadership to help these initiatives grow and sustain themselves?
Yes, indeed we do. I think we started more from a top-down central organizing way of doing things. And I think this notion or direction that we are heading of making every neighborhood great to age in is something that we are going to begin by co-creating with local communities, beginning with the partners to have a pulse of the lay of the land, and also working through them and their networks to bring the seniors in to co-create some of these initiatives as well.
Thank you. Last question is, obviously the ICCP's a critical function is going to be the care coordination and the navigating function. And we've previously done quite a bit of work on social prescribing and the role of care coordinators that talked a lot about. We don't really quite know those roles. We don't necessarily know how they should be educated or how they fit in the system. Is there some sort of approach within the ICCPs to identify, how that role is developed and how it's supported? Is there an idea for a new professional kind of group doing that, or is that still in the process, like the ICCPs themselves, in finding out what works and then capitalizing on that as you go forward?
I think for the moment there are no such plans to create a distinct profession, because if we wear a strengths-based lens to looking at it, the ICCP is really a consortium of individual providers and partners. And residing within these partners are the expertise to be able to do some of this care assessment, as well as the care coordination. And the thinking then is, while they're in growing a separate professional pool organization, where this might inadvertently then create another layer. I think in this regard, there are no good or bad options here. But for now, we've preferred to take the approach of tapping on the strengths.
Okay, thank you. Well, thank you very much. We've come to the end of our time. It's been a very rich morning, afternoon, or very late evening session for those of us in Europe. I'd just like to thank everyone for providing all of their passionate and excellent presentations. To Leanne, Melissa and Jen, Fiona and Dominic, thank you so much. For those who are listening, we will be able to have this recorded webinar on our website soon, and then we will be engaging with people who've registered to ensure that they get all of the information and potentially the slides as well. If you have any further interest in what CRiHSP is providing in terms of webinars, do come onto our website and see what's happening, because we're growing in activity. Thank you to our panelists again, and we'll see you again shortly. Final note, if you're really interested in community-led integrated care initiatives, then drop us a line, because between myself, particularly Melissa and Jen, we're running a special interest group on this with the International Foundation for Integrated Care. And if any of you are coming over to Birmingham in a few weeks' time, we'll begin a process by which we're trying to unpick what the practical issues are in helping to guide these community-led models forward. And I think all of the learning we get from experience can feed into that. So that's just a little play if you're interested to join that special interest group. Okay, with that, we'll finish, and we look forward to seeing you again next time.
Okay, bye.
Bye now.